Hello, everyone. Good morning. Good morning. It is the Healthcare Inspired Podcast. We are here to talk about a specialty that I'm very excited about, and I'm excited to bring on the stage our amazing co host, Maya Turner.
Hello. Hello, everybody. Happy Monday.
I know we're here on a Monday. Are you tired? I'm exhausted, but I'm here.
Yes, I'm tired. It's fun to have a fun-filled weekend, but when you have to come back and realize what you still have to do for the week, you have to get your mind ready. That's why there's coffee and there's Celsius. Working together.
Celsius. Yes. Oh, yes. Let's hope you don't end up in the ER with all that caffeine.
You got jokes.
Hey, I come prepared. So let's talk about primary care today. I'm so excited because I get to hear Maya talk for most of this episode.
Yes, this is my
So
baby. I've been dealing with this for at least 12 years, especially with the organization that I came from. That was all my wheelhouse: primary care, preventive care, Medicare, all of that stuff. So this is my baby.
love it, love it, love it. Well, let's talk about primary care, Maya and Jennifer, but mostly Maya. So, Maya, tell us why primary care physicians are so important and kind of like what their role is in healthcare.
It's very interesting. I think primary care physicians kind of set the tone of what is needed, right? And in the managed care world, you have to have a primary care physician because they field what is necessary to manage that patient. They're responsible for the consultations that need to go out, the referrals that are needed, any new diagnoses that is without outside of their scope. And so when we deal with primary care physicians, they really are, and they should be the gauge for the compass, if you will, of how the patient's care is managed. And anything that needs outside of their scope, they should refer out and or give additional information on how to management if it's outside of their scope, should the patient choose to do that on their own.
Excellent, excellent. I'm going to admit, guys, I don't see my primary care physician probably as often as I should. I think because I know, like, okay, I broke my foot, I'm going to go to ortho, right? Or like I have a respiratory issue, I can't breathe, I'm going to go to this physician. Or lately, I've been dealing with a lot of ENT issues, so I go right to my ENT. And I think that sometimes a lot of people tend to do that and bypass that. But I feel like there's also something to be said about having that person you can go to that understand the full picture of your healthcare, scene and knows, okay, is going to monitor some of those things. And then I go get my test done. I had done recently, and they're like, "Who's your PCP?" And I was like, I don't know. So funny thing is though, they showed me like the chart that I had. I walked in the office, and this is what happens, guys, when you're not paying attention like me. I'm signing off that everything's correct, and it literally was in yellow for me to verify my PCP, and I literally just glossed over it, did not even look at it, and I'm like, yeah, that's right. And then they go in and they're like, just want to confirm again that this is your primary care physician. I had never heard of this provider. I don't know how it got on my chart. No idea. Never seen this person. So I'm glad they brought it to my attention again, or that was a next check the next person did, because I don't even know what I was thinking that morning. I didn't check. So I had them fix it. But it was just interesting to me that, some patients could have those days like I had, and their information is not correct. And it's good that they had that extra check and balance to have somebody else ask you again during that visit, is this correct? Because then my information could have gone to the wrong doctor. So I'm glad, because yes, they do want to send your records for things you would do outside of primary care to your primary care physician, so they have a record of what's been going on, so they can monitor everything for you. So I think it's a good specialty, or a good type of physician to have in your life. So it taught me the lesson that I need to be more cognizant of going to my primary care physician.
And that's really true. And I think especially for those who have managed care policies. Those people who have managed care policies
Mhm.
can't go anywhere without seeing their primary care physicians first. And
Mhm.
it's a catch-22 situation, right?
Yeah.
So think about it this way. So let's say you have HIV, right? If you have HIV, then all of your primary care services are going to be through your infectious disease provider because they're managing everything because HIV is the underlying condition, which could be affected by the medications that you're on. If you have end-stage renal disease, obviously the nephrologist is going to be your primary care physician because you're managing
Mhm.
all of those conditions that are associated. So it becomes a catch-22, especially if you have a managed care program. But in the same breath, if you have a primary care physician and you have specialty offices that are driven by referral only services, and you could have a PPO, if they want a referral, you need to get a referral from your primary care physician. But guess what? In order to get a referral, you have to have a relationship with your primary care physician. So if you don't have a
True.
right, right. I mean, I'm just saying because there are a lot of times when you need those annual checkups, you need those immunizations, you need all of those types of things, and because of that, if you don't have a relationship and it requires for you to get a mammogram, a colonoscopy, those types of things are done by primary care physicians. So I believe that it's all related. But if you don't have that, then it becomes, it becomes a problem. And so if you haven't done so, see your primary care provider today.
Yes, exactly. And we are going to be talking more about primary care services here in a minute, but I wanted to remind everybody that we are going to have a Master in Preventative Medicine Coding webinar on January 7th. It's our first webinar of 2025 under our new education platform, MedUtrain. We're so excited. And we're going to start the year off with Maya Turner as our speaker. There is one CEU approved officially for this event. So we're excited to have this. So jump on over to our new website for education and sign up for our first webinar. And remember, if you want to take advantage of our membership options, just let us know. You can contact us at healthcareinspiredllc.com. You can go to this link and then, of course, contact us as well. There's also the website mdutrain.com where you can contact us if you want more information about that membership. More details are coming, but you get all webinars for included in that membership if you buy the annual membership. So it's a nice way to get all the webinars and discounts on our conferences. So it's a great option. Plus, you get to ask us questions on your burning questions that you get every day, our coding membership. So it's a great way to get a lot of great education at once in one membership. So just to know that that's there. So we hope you'll get to join that event. I also wanted to highlight something that I thought of. It wasn't on our agenda, but when you mentioned the referral, I remember the days where I was in the office working and we had to get Medicaid patients in, and they had this specific plan that required them to have a referral from their primary care physician. So they would come in, and sometimes the receptionist would check, sometimes they wouldn't. And we had to look, and we noticed that the PCP they had on file was not who their PCP was. So we had a problem. So we had to always tell them, here's the deal. Your claim's not going to get paid until you assign the proper PCP. I have to have this paper from Arkansas Medicaid that says this is your PCP. It has to come from them. So we either had to reschedule them, or sometimes, of course, the doctor didn't want to, and we had to deal with it later. And so it was one of those things that caused a lot of headaches. So this is another reason why you need to make sure your front office staff is educated on this referral process when it comes to the connection between your specialists and your primary care physicians. It's not only for continuity of care, but it's also for payment, of course. It affects your payment. So I just wanted to highlight that. It was something that I remembered from my days in the office that I'm sure today still happens, but it was a headache. let's just say.
And it's really interesting that you say that, because on the claim form, when a claim is submitted, there's a box that says who is your referring provider, and if it
Yeah.
doesn't match the NPI, it causes a lot of confusion, right? And in my years as working in this field, and I mean, both you and I, Jen, could say that we worked almost every position in an office, right?
Mhm.
I
Yeah.
think it's important that why it's important, especially with a managed care program, and you have your PCP on file, and the what's the word I'm looking for? The cutoff to select a primary care provider when you don't have one. So most insurance plans say it's the 15th. So anything done before the 15th of the month or the middle of the month, and I'm not saying that it's all, but most of them is by the 15th. So if you do it after the 15th, you have to wait until the following month in order to select a primary care provider, because they have to set everything up for that provider to
Mhm.
get paid
Mhm.
capitation.
Mhm.
What's capitation? Capitation is a monthly amount that a provider gets for all of their patients who are enrolled with them on a monthly basis. If that doesn't happen, that provider is not getting paid, because they are the gatekeepers of all of the care that you get. So if that is not correct and you need a referral, then that provider is going to say, I didn't get paid that month for that provider. I mean, for that patient. They're going to have to go to, so, primary care providers are probably the most important thing that you could ever know about your insurance, honestly,
Mm.
because if you don't,
Absolutely.
any other specialty that you need outside of your primary care physician, you may not be able to get service because of the referral. And because of that one claim box that says, who is your primary care physician or your referring provider? If that's blank and it's not your referring physician, you could have a problem.
Mhm.
So it's very important that your specialists know who your primary care provider is, because guess what? They have to talk to them too in order to manage anything that's outside of their scope, to make sure that anything is contraacting or contraindicative of any medication that you're on. Med fights go on all the time between providers.
Oh,
Med fights,
yes. Yes.
medication fights, they go on all the time.
It's
Guess
a
what?
literal fight club, guys, but you just don't talk about it, right? It's the first rule. You don't
Yes.
talk about it.
Right, man. If I could be in the room, a fly on the wall, for every time there was a med fight for infectious disease, cardiology, internal medicine docs, hospitalists, emergency docs, these people need to know the medication lists. And guess
Yeah.
what? Who manages that? Your primary care doc.
Mhm. Yep. It's
So
true,
I just
guys.
say it. True, true,
Yeah.
true.
Yes. Okay. So let's get into segment number 2. We are excited to talk about the key services that require strict documentation. Let's start with evaluation and management services, Maya. I feel, as many probably know, you have these providers or these specialties, these areas of healthcare where it's very heavy with evaluation and management. Maybe some other areas don't bill E&M as often. They're more procedure based, but primary care physicians make their money on office visits, follow-ups, and of course other services that get combined with office visits and those services. So we'll talk about those, but let's just talk about the documentation needed in 2024 today. As of now, we are in the official updated guidelines that came to us in 2021 that have been revised in 2023 to bring in other areas of healthcare. But when we think about just for primary care, for instance, there is no reason most primary care physicians can't get a level 4, sometimes a level 5 for high risk patients. But I mean, most of the time you're managing multiple chronic conditions. If they're stable and you're writing a prescription, which most of the time you are, there's no reason you can't get a 4. But guess what? We want to see the documentation to support it. And that is our problem that we get to, is because let's just say that, you did everything right and maybe you documented it, but maybe the code level didn't support that. So maybe you documented that it was chronic, exacerbated, all that, but maybe your coder or someone who pulled the code or your system didn't pull the right code and it's unspecified or it's not specific enough. The insurance company is going to take that diagnosis code and that level of care and say, no, 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 we're downcoding you. Because they have algorithms in place, smart edits, right? That are smart enough, I guess, to say, no, your diagnosis doesn't really match the level of service you're providing to us. So we're just going to downcode it. And so this happens all the time. And if your diagnosis that you report matches the, I guess, the smart edit or the relevant information they're looking for, chances are you probably won't get that to happen. Could happen, but chances are less likely of it happening if your diagnosis specificity or severity matches the level you're billing. Just it is what it is.
Yeah, it's gosh, I can't tell you how many times I've had conversations with providers. And it's not just writing a prescription, it's documenting the medication efficacy, right? And efficacy is about how the medication is affecting the chronic condition. Is it making it stable? Is it making it worse? Is it requires titration because the efficacy is not at goal? So when there is something that is not necessarily appropriate for that managed chronic condition, the physician either A needs to titrate it, B needs to change it, or C continuation as med and document that it's stable. So when you have these types of conditions and the medication management that's associated with that, and you have more than one, or even that one condition that's not at goal, AMA says that if it's not at goal, it is considered exacerbation. So if you have one chronic condition that is not at goal and the titration of that medication or the documentation of a medication not being stable or changing that from, or they're not at goal based upon that because they're not following diet and they need to take their medication, blah, 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 right? That's a level 4. Yeah, that's a level 4. And I think one of the things that really gets confusing is one, the transition from the old 95-97 guidelines for medical decision making to the new 2021, which was revised in 2023, medication or medical decision making. And I think that if providers were to consult, hello, with us in regards to, primary care management or even documenting in the evaluation and management record, I think it's important for them to know that those level 4s are important. And even Medicare has all of these programs that are contingent upon primary care management and level 4s being documented in the medical record. And now, don't get me wrong, every visit is not going to be a level 4, but I can almost put money on that 60% of primary care offices are managing Medicare patients. I don't know one Medicare patient who doesn't have at least one chronic condition. Unless there's some 70-year-old bodybuilder with 0% body fat that competes regularly, I don't think that there is anybody. So 9 times out of 10, you're going to meet column 1, which is number of complexity of problems addressed. They're going to have at least 2 chronic conditions, right? And if you are documenting appropriately for the efficacy for that prescription drug management, or if you're recommending surgery because of something exacerbating, right? Guess what? That's still a level 4 because it's in the risk column. Now, a data, I don't think that there's always something that's going to be there, but I will say that if they are checking follow-ups regularly, maybe there's a standing order in between the visits and they had to go get those labs. It's still a level 4. So I think it's important that the providers know that if you have 60% Medicare, then 60% of your level should be a level 4.
Absolutely. Well, and let's talk about another service too that, sometimes we don't think of, and I'm sure nowadays in 2024, it's definitely something people are doing, but in years past, we're trying to figure out why are they not making as much money as they should. They were not effectively carrying out a chronic care management program.
Yep.
So CCM, chronic care management. So you have the option to not really talk to the patient face to face, but still put this program in together, right, Maya? So tell us about the requirements or what chronic care management really is designed for, how it helps the patient, but also how it can help add additional revenue to the organization.
It's okay. I don't want to burst at the seams, but this is something that I talk about all the time.
I
I
know.
think, and so I think chronic care management is a tool, right? And just like chronic care management or any type of outside monitoring that's done outside the office. So this is remote care management, remote therapeutic monitoring, chronic care management. They're all in the same family. And now with this advanced primary care management that has been introduced for 2025, I think the issue is that the providers are so what's the word? They have blinders on. They're only focused on the face-to-face care or telehealth.
Mhm.
Well, questionable telehealth, right? For those services for the services that are done outside of the office. And so the problem is that because either A, they don't have the bandwidth, or B, they don't want to invest in using a contractual entity to manage these patients outside the office. But what the physician doesn't realize is that for chronic care management, A, they have to have at least one chronic condition that needs to be managed, right? And because they have to have one at least chronic condition that needs to be managed, there's also an agreement for the patient has to sign a consent. Once that consent is in place, and they do it on the same visit as a E&M service, they append the code G0506. That code is appended. Once that code is appended, the monthly chronic care management begins for ancillary staff to monitor the chronic conditions. And there's typically some sort of notification or something of that nature to say, okay, how are you doing with your meds this month? Are you having any headaches? Da, 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 da. And you have to meet a certain time component in order to bill. But guess what? If you exceed that time component, you can bill for the additional time that it takes to manage that patient. So when it comes to that, you're able to get additional monies that's outside of the E&M on a monthly basis. So you have all of these providers who are complaining about, I'm not making enough money, my blah. Well, you need to consider return on investment for
Mhm.
investing in a third party to manage your patients, where all you're doing is giving direction for the ancillary staff, nurses, MAs, whatever, who are contracted to manage these patients. And guess what? Medicare says that chronic care management, remote therapeutic monitoring, and remote physiological monitoring, as long as they're not carved within the same time frame, you may be able to bill that contingent upon the chronic conditions if they're not overlapping, right? And so I think there's a whole lot of opportunity, right? And I don't think that there's enough education, for us to give for these primary care providers to make this kind of money. And so and I think it's like 0.18 work RVUs. I'm not sure, but think about the work RVUs that's associated with that and the monies
Oh,
that's
yeah.
associated with that, in addition to your levels of service. This prevents care to the emergency room. This prevents so many different things that could escalate the patient's out-of-pocket expense and their ability to afford those medications that they need to get on a once a month basis. Then we're not
Absolutely.
talking about that. So when you think about the primary care and then the management that's outside of the office, this prevents hospitalization. That's why Medicare is so proponent of the primary care and the visits that are associated with chronic care management, remote therapeutic monitoring, and remote physiological monitoring. And with this advanced primary care initiative, the it's quite obvious that Medicare is trying to drive a message: the care
Oh, yeah.
outside the office. So yeah.
Yeah, I mean, they provided these service for a reason. They not only care about controlling costs, but they also care about, serving their members, right? Um, because it looks good for the government to see less and less admissions to the hospital, less and
Yes.
less, payouts of these things. But again, it's about patient care. Now, another service that has been around for a very long time, but still done wrong, is the preventative services. So let's just talk about the annual wellness visits, having a clear distinction between a preventative visit and a problem visit. Because yes, I've done it. I've gone to my PCP or even my other physician and said, yeah, I'm having this problem though. I know I'm here for a wellness visit, but I'm having this problem. And sometimes they might choose to say, well, let's schedule an additional appointment for that so they can kind of keep it streamlined. This is your preventative visit. We're going to do that next. Or they might talk about it and do something about it and carve that out. But we have to have clear distinction in the documentation, right, Maya?
Yes. Okay. Again, I'm bursting at the seams because I have been on my soapbox many, many years talking about this. So, first, let's talk about preventive services and what is considered commercial benefits and what is considered Medicare benefits. So, when we think about the annual wellness visit, this is a Medicare driven service. The Medicare annual wellness visit or the subsequent annual wellness visits or the initial preventive physical examination, the IPPE, otherwise known as the Welcome to Medicare. These are all considered Medicare specific benefits, right? So, with those specific benefits, Medicare has a specific list of requirements that are associated that need to be checked off that are associated with these Medicare annual wellness visits, the IPPE, the annual wellness visit, and the subsequent annual wellness visit. Those are the requirements those are the preventive care services for Medicare. But then you have the commercial, you have the annual preventive exam, annual preventive, not annual wellness, annual preventive. And these codes range from 99381 to 99397. Okay. These codes are preventive medicine codes. These are billed and these are not covered. They're mutually exclusive by Medicare payers. So if you were to bill this to a Medicare payer, you are not going to get paid. But you cannot confuse the requirements because they are completely different. And so, with that being stated, if you have a sick visit that is done on the same day as a Medicare annual wellness visit, you need to make sure you first meet the requirements that are associated with the annual wellness visit. Then you need to document that there is an estimated or there is a problem that you need to address. I always say, Jen, the E&M Snellen test. If you can cover one visit and you could see the management of the sick visit, then you have both. But if you see that the lines are grayed and you can't tell the difference, then don't bill the initial visit because you can't tell what was managed outside of the annual wellness visit.
And you don't have a reason to add modifier 25 if that's the case.
Oh my gosh. Why did you say that?
Sorry, part of the equation. I'm just laying it out there, guys. And we've talked to blue in the face on modifier 25. And
Yes.
of course, as you know, yes, we do have a modifier 25 tip sheet. You can scan right there on the screen. We do it every week, reminding people it has examples for primary care as well as other specialties. So why not download it today? It's a great tool. Just saying.
It really is a great tool. And I think because let me just divert for a second. If I talked about the annual wellness visit, let's talk about preventive care. Because with preventive care, which is the commercial, right, you got to be careful because there are no specific requirements for the annual or preventive physical exam or the preventive exam. There's no specific requirements other than you have to meet the history, the all of those things that are related, right? So a lot of times because you're billing commercially, that you think you automatically get the sick visit. It still needs the E&M Snellen test, the preventive exam versus the examination that's related to the sick visit. If it does not meet both requirements, you are not going to get it. And Blue Cross and Blue Shield says that they want the medical records every time you append a modifier 25 with a preventive visit. Why? Because it probably doesn't meet the E&M Snellen test. If you can't see it, then don't bill it. Period. You got to cover one, other. If you can't see the other for the other, that's a no-go.
Right. Great stuff. Well, and we don't want to give away everything, Maya. So we're going to leave with that little tidbit. And you're going to have to join her preventative medicine webinar on January 7th to hear the rest, guys. But our quick documentation tip, and I think Maya has also used this line before, but I'm going to take it. You got to have the who, what, where, when, and why. This is our documentation tip, guys, for today. It's as old as grade school, guys. We had to do all of this in grade school. We had to identify in a sentence or in a paragraph all these things so we could understand what these words mean. So we all have gone through this, but this is the best practice for documentation. Who, what, where, when, and why. We need all of those things in our documentation. And just pause for a second, and I want you to think about this. Think about the last E&M code as a physician that you documented or as a coder you looked at. Did it reflect the whole picture? Do you feel is anything missing that could have been better? And if the answer is yes, have a meeting, have a discussion on how you can improve the process. If anything feels off, then it probably is. So you do need to take that look. Now, we do want to go into our final segment, and we just want to talk about something that was, in the news last year. I always like to pull, if it's relevant, a case that shows what could happen if you don't document appropriately or you try to report services that aren't documented. So back in 2023, there was a press release, primary care physicians to pay $1.5 million to resolve false claims, unsupported diagnosis of the Medicare Advantage program. Now, like Maya said, a lot of patients are Medicare patients in these offices. And chances are, majority of them do have an Advantage plan. It's very common today for patients to go with an Advantage plan over traditional Medicare. It's very common. But this case, it actually looked at claims from 2015 to 2018. And this is, of course, before the guideline changes. So we had history, exam, and MDM to play with, right? And they had been using 99214 without the requisite level and complex medical decision making that this code requires. So this was before it was easier, obviously, but still, you still had to have the evidence of the risk, the management of the condition. You had to talk about, was it something that was exacerbated? All those same elements were always there. The same concept was always there even before the 21 guidelines. The examination needed to make sense. You needed to document the body systems, organ systems that you examined. And that would, of course, filter into the medical decision making that showed you had to make this decision because of your examination and because the history of the patient. So it still is that way. I mean, we still have to have that. So I just wanted to highlight that. We are going to put that case in our show notes so that you know. But quick takeaway, Maya, when it comes to documentation, this also brought out BMI and COPD, not having the specificity. How is that going to affect not only the patient, but also the reimbursement?
Well, okay. So when we talk about chronic conditions being managed, right, you have to meet the definition of a chronic condition, one, right? Honestly, I think my really big takeaway is that when your physicians are not monitoring what goes out of the door to make sure that they actually have those conditions on the claims, right? Either you have to have someone who is auditing the coding, that's looking at the documentation, or making sure that the documentation is met. So the difference between a BMI being morbid obese versus not morbid obese is when the BMI is over 40%. If your physician is not documenting that the BMI is over 40% and you're appending morbid obesity, then that's a problem. So with that case, again, you have to meet the extensive history. You have to meet the full PFSH or PFISH. You got to have 10 review of systems. You got to have 8 documented organ systems. But if that's not there and you're billing a level 4 and your documentation doesn't support that there is a BMI of 40% and you're documenting morbid obesity, or if they have COPD and there's no monitoring all year for those types of things, guess what? Those chronic conditions also affect the HCC outcome that's associated with those conditions. So, word to the wise, the who, what, when, where, and why, make sure you document that And if you're able to do the E&M Snellen test to see each condition being monitored, evaluated, assessed, and treated all day, every day,
Exactly.
and twice on Sundays.
Exactly. Well, I think this kind of ties in everything, talking about documentation, why primary care physicians exist in the first place, their benefit. We talked about some of the common services that they report. We have a QR code here for you on the screen as well. If you want to read more about that case that we mentioned, I think it's worth looking at
Yes.
and investigating how it could maybe affect your organization if you're not careful. It's really important. And then reminder, focus on the services your patients need first. Focus on them. And I'm telling you, the money will come as long as you have a good understanding of how to document appropriately. Just think about one of the services you report all the time. Think about preventative services. Have an education session with your staff, your physicians. If it's something you report all the time or common in your organization, yes, then have an education session every quarter, once a year, however often you need to do it, but make sure there is education in your organization. Not only is it a requirement under the compliance plan program guidance, if you bill Medicare, Medicaid, but it's just good business. It's good management of your organization. So thank you for joining in today. We do have a teaser for next week. Next week's episode is on ophthalmology. So one of my favorites and Maya's favorites. So we're going to talk about the I codes versus E&M codes, some of the nuances with compliance that we find in ophthalmology. So stay tuned for that. And we will see you next week, guys. Have a good one.